This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, my name is Gordon Smith. I'm a neuromuscular neurologist and chair of the Department of Neurology at Virginia Commonwealth University. And today I'm really excited to be doing a podcast about a topic I'm particularly interested in and I look forward to learning about. And that is critical illness myopathy with and without myosin-loss. And I'm really excited to welcome Shahar Shelly, who is chair of neurology at Rambam Medical Center in Israel, and Teerin Liewluck, who is a neuromuscular neurologist at Mayo Clinic in Rochester, Minnesota. Teerin and Shelly, thanks very much for joining me on the podcast today.
Well, thanks for having us, Gordon.
Thanks, Gordon.
This is a really important topic, not only for neuromuscular neurologists. Many of us, myself included, could use maybe a bit of an update or primer. So I wonder if you can just talk to us really briefly about the clinical features of critical illness myopathy.
Critical illness myopathy is an acute acquired myopathy that typically occurs in patients with a serious illness, and most of them are in the ICU. So what the typical presentation that we encounter is the patients that the underlying medical illness that prompted them to the ICU have improved, but then they remain intubated and have difficulty to wean them off the ventilation. That would be the point that we need to start thinking. It is critical illness myopathy.
Just with that as an intro, we can get to the meat of it, as it were, and just learn a little bit about the goals of your study and the main take-home points.
We set two goals for our study. Number one, we know that the compound muscle action potentials, or CMAP, prolongation of its duration is pathognomonic for critical illness myopathy. We also know that the loss of myosin is the hallmark from pathology standpoint. What we still don't know is there any correlation between these two findings? Can we use either of these factors as a prognostication for patients with critical illness myopathy?
How did you go about designing the study to answer this question?
We decided to retrospectively identify patients diagnosed with critical illness myopathy based on electrodiagnostic study, but they also need to have muscle biopsy done to be included into the study. And we do encounter the initial problem is that majority of the patients, particularly that those have been diagnosed recently, did not undergo muscle biopsy.
What did you find out? What was the relationship between CMAP duration and myosin loss?
What we found is that the myosin loss only present in 70% of the patients. Now, any CMAP duration longer than 8 milliseconds considered abnormal. But for those who have myosin loss, the CMAP duration are typically longer, at least above 10. We answered the first question that the longer CMAP duration is, the more likely patient will have myosin loss. Now, in terms of prognostication, we don't find correlation of CMAP duration with the mortality. But when we look at the degree or the severity of myosin loss, we stratify patients into two groups. One is what we call high-grade myosin loss, meaning more than 50% of muscle fibers affected by the myosin loss. We learned that this group of the patient with high-grade myosin loss has an overall higher mortality compared to those without myosin loss or those with low-grade myosin loss.
I'd like to take a step back just to clarify the electrodiagnostic criteria for critical illness myopathy. So when I'm in the unit doing an electrodiagnostic study, what criteria should I use to say, wow, this is that pathognomonic finding? Like, what's the duration where I should really be thinking about this?
So for those typical motor study that we do, the peroneal, tibial, ulnar, or median nerve, we use the distal CMAP duration greater than 8, that's considered abnormal. And for peroneal nerve recording over tibialis anterior, we use the cutoff of 15 milliseconds.
That's helpful. Thank you. Definitely something we want to write down and stick on the wall in the EMG lab. I actually found it was pretty interesting that 30% didn't have evidence of myosin loss. I was raised on the idea that this was sort of a myosin meltdown sort of phenomena. Is that just a matter of severity, or are there other differences you think in patients who have critical illness myopathy with and without significant myosin loss? You brought up, for instance, there wasn't a mortality difference. That could just be a sampling issue, I suppose, because of the size of the population. But is it just a disease spectrum, or is there something else going on?
We believe it's a disease spectrum based on the severity, as you pointed out. So with a shorter CMAP duration, milder severity, we don't see the myosin loss. But once in the more severe cases, the longer CMAP duration predict the presence of myosin loss.
Why is the CMAP prolonged? What's the underlying mechanism of the finding?
That's actually an interesting question, as is the typical feature of critical illness myopathy that you see on nerve conduction, low amplitudes, and sometimes absent of CMAPs and relative preserved sensory nerve potentials. But I think common theory about why you have prolonged CMAP duration is membrane inexcitability that plays a major role in reducing the CMAP amplitude and actually eventually causing the clinical weakness. There was one study showing in rat model showcasing denervation and high-dose corticosteroids, and they actually developed critical illness myopathy. And then they showed that when they did an in vitro intracellular recording of individual muscle fibers, they showed that they lost their ability to produce an anxious potential when they were stimulated. So that's an interesting theory. So they think that it's likely due to reduction in sodium current.
I left your article wondering a little bit what the primary cause of weakness is, or whether there are multiple causes. It's obvious why myosin loss would cause weakness. One of my mentors used to call this electromechanical dissociation of the muscle. That might behave differently than membrane inexcitability, but which of those, or do they both contribute to weakness?
They're very difficult questions. I think what we still don't know is what the connection from the membrane inexcitability that lead to the myosin loss. But we believe that both could be contribute to the cause of weakness.
Would it stand to reason that if a patient had membrane inexcitability, prolonged CMAP duration, but relatively little myosin loss, that their prognosis or speed of recovery might be better than the opposite, where there's significant myosin loss? I know your sample size was small, but is this distinction potentially useful clinically in advising patients and families?
Yes, I think despite the small sample size, but our study did show finding that suggests with the shorter duration, likely no or less myosin loss would lead to better prognosis.
Us as a clinician, we always use in muscle disease the CK, not maybe as a prognostic factor, but we think of it as a biomarker for how much the muscle tissue is affected by the disease. So it's interesting that we also had patients with normal CK levels. I'm bringing back what Dr. Liewluck said about the disease mechanism. So it's not always involving extensive muscle necrosis. So instead, it could represent, like you said before, some functional disturbance in muscle fiber, maybe due to the muscle membrane inexcitability.
You read my mind. I was just going to ask about that because, we'll see patients who have surprisingly normal or even very low CKs with this disorder, and then others who have high. And I've always wondered, those with low, are we studying them later in the disease? And it sounds like it's likely more related to the extent of myosin loss versus membrane inexcitability. So you mentioned this old animal model or animal study looking at the association between denervation and corticosteroid use and critical illness myopathy. And if I recall correctly, some of the earliest cases of critical illness myopathy were, asthma patients who had been paralyzed, right? And I found it, with this in mind, really interesting that there was one patient with myasthenia gravis in your cohort, which could, of course, just be, happenstance. But do you think myasthenia patients might be at higher risk if they're getting high-dose steroids, or for that matter, just exposed to other issues inherent in critical illness for critical illness myopathy?
The answer is yes. Myasthenic patients indeed be at higher risk, especially when they are critically ill and they're admitted to the ICU. I think this subpopulation, they use chronically corticosteroids and immunosuppressants. Corticosteroid, as we know, one of the risk factors of developing critical illness myopathy. Essentially, when they are prolonged immobilized and mechanically ventilated in the ICU, it's because of their myasthenia, it's even increasing their risk more for developing this muscle disease. When I'm thinking about it in the large scale, and maybe Dr. Liewluck, you can add here, what's the implication essentially for our listeners of managing those patients? So I was thinking one, maybe slightly more aggressive monitoring this neuromuscular disease. Yes, maybe thinking about EMG, early EMG, maybe biopsy, minimizing risk factors when possible, the use of neuromuscular blocking agents. Or essentially, if you have to use them, maybe use the short-acting agents or use alternative immunosuppressive regimens like IVIG instead of steroids. If you know they're lying in the ICU for like 2 weeks. Teerin, you had anything else you had in mind?
I think that's all a good point, but I mean, it's typical for myostatic crisis that we use IVIG over intravenous methylprednisolone. So I think that's a very good strategy.
I think this is helpful. I mean, I've been doing this for a while in my career. Now we have lots of different options, but if there was a patient in myasthenic crisis in the unit not responding to IVIG or Plex, we would sometimes use that old protocol of very high dose methylprednisolone. And, that's something one would want to be very careful about based on what you're telling us in a patient who has been critically ill with myasthenia, maybe avoiding that old school approach for maybe newer modalities.
Yes, we have more options today. And one extra thing I was thinking about is essentially tailoring a good ventilation strategy. So maybe careful attention to when you weigh the patient from the ventilator, distinguishing between is it a myasthenic weakness versus critical illness myopathy weakness. So maybe diaphragmatic ultrasound, because you never know if you want to scale up the treatment, just like to give them another pulse of methylprednisolone or continue plexing them, because maybe it's the myasthenia. That's why they can't weigh from the ventilator.
How common do you think critical illness myopathy is? I mean, you have to look for it, right? And so if you don't look, it's hard to find things you don't look for. But you went back in your database, and Mayo Clinic looks like a pretty busy place. You came up with like 20 patients over 25 years. I recognize that more recently we haven't been doing biopsies, but is this a rare problem? Do you think it's more common than perhaps your case ascertainment would suggest?
Yeah, I think it's more common and probably even underdiagnosed. We look at it recently. If we include both patients who have muscle biopsies or who did not undergo muscle biopsy, we come down to roughly 6 to 10 patients a year.
Something reasonably common. We should definitely be keeping our eyes out for that. This is almost completely unrelated to the topic of the paper, but something I was curious about since I have you. How clinically important is critical illness neuropathy as a cause of weakness?
So in our study, we actually had close to 70% of patients showing evidence of coexisting critical illness polyneuropathy. We're not the first to say that an overlap between the two conditions. This maybe it highlights what you said before, the difficulty in distinguishing between them based just on clinical representation. But we know the pathophysiological mechanism and clinical features are a bit different. In polyneuropathy, the axonal polyneuropathy affects sensory nerves as well. And it's also showing reduced CMAPs, but also reduced SNAPs. And I think generally the risk factors are similar. I mean, sepsis, systemic inflammation, multi-organ failure, all these things that lead to eventually more microcirculatory dysfunction, as they call it. So it's difficult to distinguish between them eventually.
If our listeners had to take home one point from our discussion, or maybe one point that we haven't discussed, what should that be? And I'll ask each of you guys that. So Teerin, maybe you go first and Shelly second. So we'll get two. What are the 2 points that folks should remember?
So I think the important point to take home is that the electrodiagnostic study can be helpful in identifying patients with critical illness myopathy by looking at CMAP duration. Or those typical nerve is greater than 8 milliseconds are abnormal. The longer it is, the more likely patient have Myosin-Loss.
Shelly?
As we all are busy clinicians, the understanding that prognostication and recognition of high-risk patients is important. Have that in mind when we see those sick patients that are very difficult to treat. Just as you asked me about the myasthenic patients, this awareness in the ICU that you have another entity that can cause the muscle weakness. Being aware that muscle biopsy can be useful if you're having a young patient that have a good prognosis from his general problem, the reason which was admitted to the ICU. So for me, I mean, this is the take-home message for the neurologists who are listening to us. Just have this in mind that you could use prognostication tools and look at those subpopulations that can profit from recognition of high-risk patients.
Well, thank you so much. This has been a really fun conversation. Thank you again. I've really enjoyed it.
Thank you, Gordon.
Thanks, Gordon.
Just finished talking with Teerin Liewluck at the Mayo Clinic, Shahar Shelly in Israel, about their really interesting article on critical illness myopathy and the role of myosin-loss. Lots of really great clinical information. This article is in the July 9th issue of the Green Journal Neurology, and I hope all of you have a chance to look at the article and read about the details.